All right, so let's continue here with the functions, including the support, protect, movement because of the skeletal muscles, storage. Now we're going to focus a lot on this one because this is, movement, protection, right, support, that kind of all makes sense. But in terms of storage of calcium phosphate, we're going to see that we store calcium for the blood vessels to use. So when you need more calcium because you're not eating dairy, you're not getting enough calcium through supplements, what would happen then is that you will start releasing more from your bone. And there's always that balance between storage and destruction. When we're always removing bone and replacing it. So something, and we're going to see that, in areas of the body where you have a lot of tension, you're going to have replacement almost continuously. We don't think about it, but your distal femur, where it connects with the tibia, that area has a lot of stress every day. Think about your body weight goes on it as you walk, as you get up, as you jump, all those different movements. That's a lot of stress, and we replace that distal femur, the bone matter there, about once every 6 months. Now, most of the time we don't realize that we're having this remodeling of bone tissue until a couple things. One, God forbid, you get a broken bone. Or two, you put braces on. When you put braces into your mouth and your teeth, you're reshaping the actual alveolar process, the actual joint between your tooth and the mandible. And as you're reshaping it, you're moving that bone around by causing stress. And then you can see, if you ever watch those videos where they really see, kind of put braces on, and it's not just simple braces, they have kind of a way of putting the kind of bands together, and it's kind of amazing what they can do with people's teeth to kind of straighten them out so then they can even chew properly. And we're not talking about you have an underbite and an overbite, right? We're talking about your teeth are so bad that you're gonna have the molars not making contact with each other. And now you're not gonna be able to bite, things like that. So important things. Now obviously, underbite, overbite can be important too, but chewing is probably more important, right? So when we talk about storage, calcium phosphate, there's always a destruction, always a remodeling. Blood cell production, your red bone marrow. Your red bone marrow, location of stem cells that will differentiate into RBCs, red blood cells, WBCs, white blood cells, and then platelets. So all of your cell production for RBCs, WBCs, and platelets occur in the bone marrow. And we're going to see that as infants, we actually have more areas of the body that produces white blood cells and red blood cells. As we age, those areas kind of stop producing those areas, right? So liver is one of those where really early on, the liver actually produces red blood cells. And as we age, it kind of stops doing that function, and it's only solely located in the red bone marrow. Now, components of the skeletal system, again, a huge, huge link between bone and cartilage. We'll talk about those independently coming up. So cartilage first. Anything with the root chondro refers to cartilage. So chondroblast, chondrocytes. Chondro means cartilage, blast, build. All right, we're going to see two versions of this. Chondroblast, forming the cartilage matrix, and then later on, osteoblasts. And we've already heard of one, fibroblast, when we talk about connective tissue. When we see these chondroblasts, and those chondroblasts has a lot of the kind of a bluish extracellular cartilage matrix around it, well, usually that means that they have made a lot of the matrix, and now it's surrounded by its own matrix. And we call that then a chondrocyte. They're found in little pockets called lacunae. Lacunae, another kind of fancy, like a Latin name for lake. So we're gonna see, I'm just gonna move our slide over to show this. You see that there's like a, these are the actual cells right here. And then you have an empty pocket. These are empty pockets that are the lacunae that they're resting on. So it's not like this is one big cell. No, this is a cell, and then it has an empty pocket filled with fluid here, right? That's a lacunae that they're resting on. And then this is the matrix it produces. So once we see that that there's a lot of matrix material completely surrounding the chondroblast, it then changes name into a chondrocyte. On top over here, these cells are not encased completely by its own matrix yet. Then these cells can still produce a lot of the cartilage material, and they're called chondroblast. We're going to see that in some areas, especially early on in gestation, we're going to have a layer of fibrous connective tissue here at the very end of our cartilage. Well, that fibrous connective tissue allow new osteoblasts to come down and form new cartilage material. Now we see this at the epiphyseal growth plate, where we're going to have new cells, new chondroblasts being produced up here. As the chondroblast starts being formed, then you start forming more matrix over here and over here next. And what happens? As we start building more matrix over here, we're extending the cartilage upwards, allowing the cartilage to grow. So having this perichondrium collar allows us to extend and lengthen this cartilage. Now, the good news is we see this when we are growing. The bad news is the areas where we need it, right? Especially at our long bones, at our joints where they're freely movable, we don't have this perichondrium. And because there's no perichondrium, there's no healing possible. The matrix contains lots of collagen fibers for strength, proteoglycan for resiliency. So a combination of strength, rigidity, and then the ability to kind of push down and in, and then it snaps back. So there's a little bit of movement possible. Perichondrium, that external double-layered connective tissue sheath, covers cartilage except at the articulation ends. So at the areas where you would see, bone connecting with another bone. So think of your elbow or your knee. On your knee, you have a distal femur, and then you have the proximal tibia making contact with each other. What happens if you run a lot, right? What happens if you jog or you play a lot of basketball where there's a jumping effect and sprinting? What happens is you're gonna, wear down that cartilage pretty quickly. And eventually, that cartilage, it doesn't have a perichondrium there. So there's no replacement of the cartilage. Once you wear it down, you wear it down. You do not replace, and even worse, there is basically no blood vessels that are found in that area. So there's very little to no healing. The perichondrium is an inner layer containing chondroblasts that can provide healing and remodeling. Only though at the epiphyseal growth plates we see this in adults and in adolescents. Once the epiphyseal growth plate seals, this inner layer is not found. The outer layer contains blood vessels and nerves, but this is outside of the actual cartilage material. There are no blood vessels in the cartilage itself, right? In the cartilage material right here, it's so dense, you're not going to have room for blood vessels. Articular cartilage covers bones at the joints. Now again, I hate to use, I don't mind it, right? Like meat and food, but when you eat a drumstick, notice how nice and shiny the ends of the drumstick is, right? When you're looking at it, why is it so nice and shiny? It's nice and shiny because that shiny material is this articular cartilage. The bone itself is not that shiny, it's not that, right? It's dense, it's tough, it's coarse, it's strong. But the very ends where the bone meets with another bone, it's nice and smooth. The reason why is simple. If you're gonna move your joints a lot during the course of a day, you want everything to be smooth. Because if there isn't that smooth movement, then you're gonna have rubbing, friction, pain that occurs. Now, with us, obviously because of gravity, we will always have that kind of continued force of, our body weight. And our knees can sometimes wear out, especially the articular cartilage. Now, a basketball player some of you might have heard of, Greg Oden. Greg Oden was a #1 draft pick before, he was picked right before Kevin Durant. And then, I believe that now it's like a long time ago, right? But Greg Oden played like 1 year, and that's it. They knew he had degenerative knees even before he went into college. So he played 1 year of college, he should have just skipped, right? But what happened was, because he had such degenerative knees, well, the degeneration occurs because the end of his femur and the start of his tibia, that articular cartilage found there, was rubbed away, right? He didn't have the normal amount of cartilage that most people his age should. And what happens then? There's no more cartilage, there's bone-on-bone contact, and as there's bone-on-bone contact, what's gonna happen? Pain, right? And when you have pain, you think you can tune it out. But now every time you run, right, that there's pain. Every time you jump, there's pain. Eventually, the more you do it, the more bone-on-bone, the more bone spurs you're gonna have, and eventually the only thing that can treat it is a knee replacement. It's just a matter of time. Now, in terms of, the articulating cartilage found at the end of long bones, there is no blood vessels that go there. There is little or no regrowth of articular cartilage after being damaged. You'll hear of people damaging their meniscus. And once I hear people damage their meniscus, you would rather have a torn knee ligament than to tear your meniscus. The reason why is simple. Torn knee ligament, we can replace it. It might take you a year to get back, but you'll be fine after that year. If you tear your meniscus, there is no good plan. So you tear the meniscus, which is cartilage that are found in your knee. Well, once we tear it, we can suture it back up, but since it's avascular, even if we suture it, there's no guarantee there's gonna be healing. So people like Derrick Rose, what happened with him? Well, he ripped his knee meniscus, right? They tried to suture it up. He was out for almost 2 years because they were having so many issues with the suture. So once you tear it, the other choice besides just suturing it up is to cut it. And that's what most basketball players and football players choose to do, right? Since it's ripped anyways, we'll cut it off. So then you can at least move around. The problem then is you don't have as much meniscus for the rest of your life, right? And that will become an issue as you get older. Right, question?
Is that the same with your mandible fossa?
Yep, especially you have discs that can wear down, but the problem is you're not going to get an artificial mandible, right? So in terms of the knee, whenever I hear people have degenerative joint disease, whenever your parents getting osteoarthritis, or God forbid, people that are younger getting osteoarthritis, the thing is, there is no good treatment. The only treatment that we have is to deal with the pain. Now, in terms of what they've done, and I kind of mentioned this, I think, in our class before, every now and then you'll hear of people getting microfracture surgery, and that happens in the knee joint. They actually are not kind of healing a fracture. When you have microfracture surgery, you think that you're kind of, you have some damage in the knee and you're healing a small fracture, right? No, what they're really doing is causing small fractures, right? At the distal femur and the proximal tibia. They're causing them. So then hopefully that will cause a stimulus for your cartilage cells to reform more cartilage. In other words, I have never heard of a doctor saying, we've had a successful microfracture surgery, right? Never will you hear that. Whereas if you have like a knee joint replaced or you have a ligament replaced, they will say that. They're like, yep, it was successful, everything went great. But microfracture, they never say that because it's so hard to stimulate that regeneration of cartilage. Now, we're gonna see why in a few minutes, right? In terms of growth of cartilage, and this is where you have to be careful because we're gonna see that we're gonna use the same names, appositional, interstitial, growth in bone and in cartilage, but they're complete opposite in all right, when compared to each other. Appositional growth occurs as new chondrocytes and blasts are formed and new matrix grows at the periphery. So right here, so you have perichondrium right here, you have new cells come in, those new cells become osteoblasts, they start making cartilage matrix. And what happens? Well, before the cartilage ended here, right? But now I have new chondroblasts up here. And now they start forming cartilage up here now. What happens? Well, I've extended that cartilage up a bit. That's just that growth, appositional growth that we see in cartilage. So growth in length in cartilage is appositional growth. Now, what else happens? Once we start forming a little bit of cartilage material, we've extended that material upwards. Now that chondroblast will fill in any large gaps, allowing us to kind of grow in width. Growth in width is interstitial growth when we talk about cartilage. So again, know the difference for the quiz. Interstitial in cartilage is growth in length. Appositional in cartilage, let me rephrase that. Appositional is growth in length, and interstitial is growth in width. Again, appositional, length, interstitial, width. Now that's in cartilage. Now let's take a look at this. I know we had some specimens that we can look at previously. So in terms of bone histology, bone matrix is like reinforced concrete. Do you guys know what rebar is? Rebar is, if you've ever seen people lay down concrete now, when they're building a new building, when they're kind of making it or reforming a new road, right? What you see with the concrete is they don't just lay concrete down by itself. There's a lot of steel. There's like iron, rods and steel rods inside. That steel rod is called the rebar. Now, why do we have those steel rods? The steel rods allow you to move slightly without crumbling. If all we had was just concrete, and all of it is just concrete, number one, it'd be really heavy, and then number two, if there's any movement at all in a building's foundation, the concrete would shatter, right? And that's why before the late 1800s, before we put rebar into concrete, no building was above a 10-story, 12-story building. Once we start putting rebar into the concrete is when we start building these high, tall skyscrapers in New York. So the rebar found in the concrete allows the building to slightly sway. If you've ever seen that video of, I believe it was Tokyo, when they had this huge earthquake in 2011, right? Eventually it caused tsunami, it caused a Fukushima nuclear power plant incident there. It was like a magnitude 8 something earthquake. So it's a huge earthquake. And in Tokyo, the buildings are huge, right? They're very tall, some of them like 60, 70 stories. You could actually see the top of the building swaying up to 30 degrees. And people are getting sick because it was swaying so much, side to side, from the earthquake itself. The thing is, that's what it's supposed to do. It's supposed to sway. And it's because of the rebar, it sways without rupturing. If it wasn't for the rebar, it would just collapse. There would be no swing. There'd be no load management. The actual building would just collapse, right? So the rebar allows us to have a little bit of flexibility in that concrete without it crumbling and falling down. So that rebar is what collagen is in our bone. They did a video a long time ago. They did a real-time x-ray out of an NBA basketball player. It was a while ago, so you guys probably don't even know him. And all he did was he bared down and he jumped and dunked, right? And what they did was they actually saw what happens to the femur as he bared down and from a standing position jumped up and dunked. And what they saw was this: the actual femur bends a lot when he was bearing down. And then when he jumped, right, it kind of snapped back and it acted like a spring, right? So then he can launch himself in the air. So you need that ability to bend slightly. And then as you about to jump, it snaps back up, and it allows you to propel your body up more. Now, even more importantly, what happens if we fall? When we fall, you need your bone to slightly bend, right? If it doesn't bend, if it was not, there's no collagen at all, it would just rupture and break. You need that flexibility of the collagen fibers. Now, if it was just all collagen, then it'd be too flexible. You need the reinforcement of the calcium phosphate or hydroxyapatite. Remember, hydroxyapatite is calcium phosphate, right? Collagen is organic, flexibility. Hydroxyapatite, calcium phosphate, is an inorganic, allowing us to have toughness and denseness. Now I'm going to show you a couple of pictures. Some of this, if you guys watch the movie, probably Unbreakable from a long time ago, or Glass, right, from M. Night Shyamalan for a few years ago, the person that was the character, the Samuel L. Jackson character, has something called Osteogenesis Imperfecta. With Osteogenesis Imperfecta, we're going to see in a second just how short these kids are. And usually they're in wheelchairs, right? And the skull are really misshapen. Look at the leg. See the leg bend like that? No. What happens with osteogenesis imperfecta is that they have a problem not with the calcium phosphate, right? With osteogenesis imperfecta, they have a problem with the mutation in collagen, right? They have enough calcium phosphate, so then their bones are dense. The problem is every time they fall, every time they get knocked over. And if you're a child, how many times do you fall when you try to run, right? Or even worse, what happens when you go through the birth canal? All right, when you go through the birth canal, you guys have seen kids that come out and their heads look different. It's a very violent process. So what happened is none of the bones of the skull have functional collagen. So as the baby's head squeezes through the birth canal, instead of kind of reshaping like ours would, so then it can get through the birth canal, the bones in the skull just break. As they break, the baby's gonna look completely different than what you expect, right? And they're gonna look very foreign because they have all of these broken bones. And that's the thing with osteogenesis imperfecta, is that these bones continually break on them. They break so often that usually they're in a wheelchair by the time they hit, right, their early, toddlerhood. It's very sad. What makes it real sad is you would imagine that maybe it might not hurt as much because they break it so often. It hurts just as much as we would if we would break our bone, right? And these kids have severely broken bones that shatter completely. And the weird thing is, one way we can tell that they have it, one way we can tell that they have the actual osteogenesis imperfecta is actually looking in their eyes. Right? You see how they're looking at the white of the eyes? They have blue sclera. Very uncommon to have blue sclera, right? But anytime you have a child that's born or you have a child there that has blue sclera, we almost always think of this condition. That's why they show the eye so often. We say it's pathognomonic for this condition right here. Right? I think this baby has had the leg actually removed here. But this is just the end right here. But take a look at how many fractures they've had, even as a baby. So we need functional characteristics of both. We need the collagen to be flexible, and then for strength,